I'll be happy to entertain any questions if anyone has any. Jenna, do you have a mic? One that works.
Hi. Two-part question regarding treatment protocols. You inferred as much when you mentioned celiac disease, but we know a primary cause of inflammation is intestinal permeability. And we also know, for example, that traumatic brain injuries can be a causative factor. So the first treatment protocol question, part one, is when you're addressing many of these pools of symptoms, how are you directly treating the gut to address other presenting signs and symptoms, whether that's in the brain? And then part two is the etiology is also always has a reference point. So a specific example is if a special forces individual gets in a car accident, their nervous system can more than accommodate that, whereas for us lay people, that can be particularly traumatizing. So it's what the nervous system is accustomed to. So are you able to, through different tools and resources, help people to expand what they know that their nervous system is capable of, and then therefore help you directly with your treatments?
Excellent question, and complicated, but let me kind of take it apart one at a time. So first, talking in terms about the gut. The gut is a huge issue and becoming rapidly one of my favorite topics. If you look at celiac disease, about 30%, 35% of the population is genetically predisposed to developing celiac disease. But only 3% of those people actually develop celiac disease. And yet, pretty much everybody is exposed to gluten from wheat. So why is it that only 3% of those individuals who are susceptible, and all of whom are getting exposed to wheat, subsequently develop celiac disease? There needs to be at one point some assault on the gut, some disruption of the gut-blood barrier. And that can come from chronic stress. It can come from chronic use of nonsteroidal anti-inflammatory agents, Motrin, Advil, things that we use over the counter and take for granted, and yet chronic use of those medications, which get popped like candies, 75% of individuals taking those medications on a regular basis will develop ulcerations in the small intestine. So we've got lots of things which are disrupting the gut-blood barrier, end result of which is things are moving across into the bloodstream that have no business being there. And the body then starts to set up an inflammatory reaction against that. So understanding how the gut is functioning, and there's a number of tests that we can do to look at that, becomes crucial in part of the workup that we're doing with these individuals. Because it's not just celiac disease, it's also HPHPA. HPHPA is an organic acid that's produced by a Clostridial species in the gut, and in high levels, that we can measure in the bloodstream, in high levels, it actually creates psychoses. And we've in fact found high levels of HPHPA in a number of people. This is bacterial overgrowth. This is this dysbiosis. So paying attention to the balance of the flora in the gut, paying attention to sealing the gut so that things aren't moving across into the blood barrier is crucial in terms of how we treat these people. So that is part of what we do. So we look at diet. We look at specialized testing that helps us understand what's moving across and what isn't moving across, and whether or not you're digesting your food or you're not digesting your food. So that becomes a very big issue. There's a huge amount of data that moves back and forth between the gut and the brain. The gut is rightfully referred to as the second brain. And so understanding that, we are just at the beginnings of doing so. But one of the things we're beginning to understand is that dysbiosis, that irregular amount of flora in the gut. And many of you who are sitting here who've heard me get excited about this before. There's 100 trillion cells sitting in the gut. It is 10% of the DNA in our body. 90% of the DNA in our body. 10% of the DNA in our body is human DNA. 90% of the DNA in our body is bacterial DNA. So what would happen if we changed over the DNA in the gut? Well, it turns out that there's some really interesting early studies where people who have received fecal transplants, that means stool from somebody who's completely healthy into stool to somebody who's not so healthy. We do this for Clostridium difficile infections. But a couple of interesting things have shown up in the literature. A patient with Parkinson's disease who got a fecal transplant for Clostridium difficile infection, their Parkinson's goes into remission. A patient with multiple sclerosis gets a fecal transplant for a Clostridium infection. Their disease goes into remission. We in our own clinic have treated 2 patients with Crohn's disease, both of which have gone into remission with fecal transplants. So this whole business of the gut is an evolving concept and an extremely important one, and one that we pay a great deal of attention to. Now I have to remember the second part of your question. Resilience. Excellent. So the second part of the question is about resilience. Can we, in fact, regenerate that degenerative nerve tissue we've talked about? And the brilliant answer is yes. We can, in fact, build resilience into the system. How do we do that? Exercise regenerates gray matter. Exercise downregulates the microglia. It downregulates the inflammation in the brain. How else can we do that? Meditation. Meditation, 20 minutes a day for 8 weeks, has been demonstrated to increase the amount of gray matter in the brain. We are growing new brain. We can repair the brain with these kind of processes. There's experiments going on, Mr. Fit program that Liz Stanley has put together with the military, where she's been looking at teaching the veterans relaxation techniques, meditative techniques, before they're deployed, to see if we can reduce the incidence of post-traumatic stress syndrome in the field after they've been deployed, to see if we can improve their decision-making in the field. And the early data on that is that, yeah, actually we can. So this business of building resilience into the system is a very important area, and one that's going to continue to bear a great deal of fruit. So that's extremely important in terms of what we're doing. So yes, you can build resistance. Yes, you can repair things. Yes? Shalom. So that's an excellent question, and one that we keep grappling with. So C-reactive protein is a marker for inflammation in the body, but it's really a marker for peripheral inflammation. It's not a good marker for brain inflammation, and we haven't been able to get good correlation with that. There's some studies that suggest that in depressive disorders you'll see elevation of CRP, but the reality of the matter is we don't have good peripheral markers to look at the inflammation in the brain. We have to look at the symptoms that tell us the inflammation is there. But certainly CRP will give us an indication if there's inflammation elsewhere in the body, and we need to go look for that. Yes?
You have described that you have been on over a 30-year search in coming to the research, the conclusions, and be able to develop the clinic in the way that you have. What do you see happening in medical schools that would lead any of us to be hopeful that the coming physicians and medical crew would be able to discover what you have discovered sooner?
Well, the good news is docs are the most parochial creatures on the planet. We didn't see it in medical school. It's really hard to get us to believe that it exists. So this is slowly but surely, this concept is slowly but surely seeping into the medical curriculum. I am hopeful that this book will help contribute to that. Certainly lectures that I give at Georgetown and teaching the students about this is waking them up to this. But you're right, we're not there yet, and we got a long ways to go. But this book, the lectures that I do, the teaching that I do, the work that I've been doing with others is about changing the consciousness so that more people will think this way, so that we get better answers and better solutions.
Documenting inflammation on the brain through scans or anything like that, or just assuming that there's inflammation?
So the question is if I'm documenting inflammation in the brain. As I said, we have a couple of biomarkers, TGF-beta1, C-reactive protein, complement factor 4A. So there's a couple of factors we're looking at and trying to understand. We're also trying to look at the gut microbiome. We've got a research project that we're going to be undertaking in the next couple of months to look at whether or not we can see within a change of the types of flora in the gut, whether that will give us a fingerprint for a specific type of disease. We don't know if that's there yet. Mostly, you look at the symptoms and it's on the basis of the symptoms. Now, how did we get there? We got there from the basic science research. We got there from the clinical research that's been done on humans that looks at the cerebral spinal fluid, that looks at the functional MRI studies. And so we have a huge amount of research data sitting there that we're now bringing into the clinic. But being able, if I started doing functional MRIs on everybody, yeah, I could demonstrate it. It's a very expensive way to do things, and I think unnecessary. I think we can do as much simply taking the literature, knowing what other researchers have taught us and learned, and be able to put that into practice. So is there a relationship between dementia and Alzheimer's? So Alzheimer's falls in the chronic degenerative disease category, as does multiple sclerosis and amyotrophic lateral sclerosis. There is unquestionably inflammation in those conditions, and there is unquestionably involvement of the microglia in those conditions, but we're not sure we understand what that involvement is. We originally thought that it was the microglia themselves that were creating the problem. The data now pushes us that it's dysfunction of the microglia, that their failure to actually do a proper inflammatory response that may be part of the problem, but we don't know the answer to it yet. They are neurodegenerative, they are neuroinflammatory diseases, but there's something different about them than these other conditions. The beauty of these other conditions is we can recover from these. We still haven't figured out how to recover from the others. Yes?
And how do you distinguish between what I typically think of as inflammatory inflammation of the brain called encephalitis and this inflammation of the brain that you're talking about?
So the question is the difference between encephalitis, which is officially inflammation of the brain, and the inflammation I'm talking about. And in a sense, there's not a lot of difference. So a true encephalitis, is a generalized inflammation of the brain, which can have devastating consequences and potentially be fatal. Think of this as a lower burn than a generalized encephalitis, but it is a type of encephalitis. So chronic fatigue syndrome, we are getting close to renaming to myalgic encephalomyelitis. Chronic fatigue syndrome, we're getting close to renaming to myalgic encephalomyelitis. I sit on the advisory board at Health and Human Services for chronic fatigue syndrome, and there's been this huge discussion about what chronic fatigue is, and the argument now is pushing, saying, you know what, chronic fatigue is such a vague term and so misused in terms of diagnosis that we need something a little bit more specific and more consistent with the physiology. And so myalgic encephalomyelitis at the moment is the term that we're moving toward. Not there yet, but moving toward. But CSF is officially returned to as ME-CSF. So it is a form of encephalitis. It's inflammation in the brain. It's a matter of extremes. Other questions? What do we do for the neurotoxins? So there's a protocol that's been developed by Richie Shoemaker, and actually it's pretty straightforward. There's a number of things we have to do. The neurotoxins are fat soluble, and so what happens is they get excreted into the gut on a regular basis, trying to get rid of them, and we can put something into the gut that will suck them up and take them out. And so that is cholestyramine, a well call, and over a period of time, we literally drain the pool, and we keep pulling these things out. We also help some of the detox pathways with things like glutathione and N-acetylcysteine. So there's a whole detox process that we can put people through. But it's time-proven and pretty straightforward and very safe. Sandy.
Gary, how do you integrate this new understanding of inflammatory brain issues with traditional osteopathic practice?
So how does this business of inflammation tie into traditional osteopathic practices? Remember, one of the things that keeps the brain inflamed is chronic pain. So how is it that we need to do we need to pay attention to structural reintegration. We need to look at the musculoskeletal system, which is 60% of the mass of the human body, and we need to pay attention to how that's functioning. Because as long as that continues to dysfunction, it sends pain signals to the brain. And so we have to work in addressing that to quiet that down. So osteopathic philosophy has a whole series of beliefs in terms of how we're helping the body repair and initiate its own healing process. And that ties very much into reduction of inflammation throughout the periphery of the body, but also stopping those constant pain signals so that inflammation in the brain will quiet. Other questions? Yes, ma'am.